Welcome to this show discussing problems and issues of health with Dr. Alsena. For this segment of the show, I'm going to continue to talk about diabetes mellitus. When I left off last week, I went through the whole process of explaining what hyperglycemic hyperosmolar syndrome is. In this segment, however, I'm going to talk about, as I promised last week, hypoglycemia. Hypoglycemia is an extremely dangerous, if not deadly, part of diabetes mellitus. It is so complicated that I won't be able to finish all the things that can cause hypoglycemia in this particular segment, because there are many more things that can cause hypoglycemia than diabetes itself. So I will then talk about just the diabetes-associated hypoglycemia. And next week, I'll wrap up the series with the non-diabetic associated hypoglycemia problems. What is hypoglycemia? Hypoglycemia is when the blood sugar becomes too low. The normal blood sugar is between like 80 to 120, thereabout. When the blood sugar drops too low, that can cause a lot of problems. Okay, and what are the things that can cause someone blood sugar who's diabetic to become too low? Number one, the person takes too much insulin, assuming that the individual is on insulin. Then that can cause the blood sugar to become too low. Number two, the person is taking oral hypoglycemic agent. And then the person takes those pills, one or two of them sometime, and for whatever reason, the person either was not eating or forget to eat or whatever, or took them on excess. That can cause the blood sugar to become too low. They are the two most common things in terms of medication itself that is strictly have to do with diabetes type 2. Sometimes the individual is involved in some other issues, some other diseases, and they completely forgot to take the medication. When they do, they take too much of it, and then the blood sugar drops rapidly. What are the symptoms of hypoglycemia? Well, dizziness, fatigue, nausea, vomiting, anxiety, rapid heart rate, confusion, seizures, and of course coma, which can lead to death. This is the most dangerous aspect of it. And it is unfortunately very frequent that those things happen. Very, very frequent in people who are taking medication to treat hyperglycemia, i.e. diabetes mellitus type 1 or type 2. Very frequent. Unfortunately, what happens is that sometimes the people are being prescribed too much insulin. That is the reason why now there's a pullback to not control their blood sugar too finely. The more one tries to control the blood sugar too finely, the more one risk to cause the development of hypoglycemia. Why is hypoglycemia so bad? Well, it is so bad because without glucose, one cannot process oxygen. Without oxygen, the brain cannot function. So you need glucose to process oxygen. So the lower the blood sugar, the more likely the person is going to develop brain damage. So if one is having recurrent hypoglycemic on and off over the years, that person is at risk of ultimately developing severe damage to the brain, which can lead to, in fact, to dementia, etc., or sometimes stroke, etc., and chronic seizures as well, because it depends what part of the brain that is damaged. That determines what kind of chronic symptom relating to the neurological issues that the individual in question is going to have. So to evaluate someone with the possibility of hypoglycemia who's diabetic, assuming the person can give a history, sometimes they can, they'll rush them to the emergency room. And of course, you could do a finger stick quickly because the person would then know that they're diabetic, and you could quickly realize that, oh my goodness, the sugar is very low. And then the evaluation is done, blood is drawn, sent to the laboratory, and then an EKG is done, a CAT scan of the brain is done on an emergent basis. And before all that is done, of course, the patient is given 1 amp of D50, namely glucose, that quickly stabilizes the problem. But it's more complicated than that. If this happened to the individual because of insulin, then it is pretty straightforward, because the half-life of regular insulin is 4 hours. And the patient is given the amp of D50 and then start an IV, which D5W or D5 with some saline on it, depending on the underlying problem the patient may or may not have. And then you could settle the situation depending on how bad it was and the other situation involving with the patient medically or socially. Then the patient may have to be admitted to straighten the situation out. However, it becomes much more complicated if the patient's blood sugar drops as a result of oral hypoglycemia, hypoglycemic agent. No matter which one it is, this patient must be admitted to the hospital. You say, well, how so? Well, because it takes 72 hours or more, sometimes 4 or 5 days, for the blood sugar to stabilize when one is taking oral hypoglycemic agent. And sometimes it's worse than that if the patient has renal insufficiency. If you have renal insufficiency or kidney failure, then the situation is much more complicated. Because you have to understand that 15% of glucose that is metabolized in the human body is metabolized through the kidney. That's right, 15%. So that is why when you're treating somebody either with insulin or oral hypoglycemic agent or a combination of both, you must decrease the dose accordingly, because the 15% that is metabolized by the kidney is no longer in action. The kidney cannot do that. The kidney is either insufficient or the kidney has already failed based on other chronic problems. Sometimes it's the diabetes itself that can cause somebody's kidney to get damaged in a chronic way. So if who's treating the patient fail to comprehend that, and the patient get too much medication, or the patient herself, by accident or whatever, take too much of it, it takes several days for the blood sugar to come back up. So all that time, the patient in the hospital getting an IV infusion of glucose, because it takes a long time to get rid of that oral hypoglycemic from the body, in particular when the kidney is not working very well. The same thing happens if the patient has liver disease that are really chronic in nature. That also takes a long time, because the liver is too sick to properly get rid of these material in a quick fashion. So it is harder to treat hypoglycemia in someone who have bad liver and someone who has bad kidney. Very, very important thing to remember. So those tests would have gone to the laboratory. They take about an hour or so to come back. You will have the metabolic profile. You will look at the liver functions test. You will have the kidney function test that will enable you to see if the patient really has a problem with the kidney and or the problem with the liver. Or for that matter, if the patient has an infection, acute liver infection, that, such as hepatitis, that may play a major role in the whole process that I'm describing. Similarly, if the patient has urinary tract infection, that may have gone to the higher level, such as a pyelonephritis. So it is a very complicated process. It's one thing to discover it. It's another thing to know exactly how to manage it and manage it properly. Okay, so because as soon as you bring it down in the morning, a few hours later, you get a call again from the nurse, it's down again. It's going to be down again, especially if it's the result of oral hypoglycemia. So knowing that, then the patient must remain on an infusion, IV infusion, that has enough sugar in it. And if the patient is able to eat, he or she has to be encouraged to eat, in particular, food that has glucose, because this is a very deadly condition. And every year in this country and across the world, a lot of folks die as a result of hypoglycemia. Serious, serious, serious condition. So now that that has been discovered and treatment has been given, and then you have to then, at what point you taper the dose of the glucose, and then you then resume treatment, either with the different types of oral hypoglycemic, or the same but in a smaller dose, or if it was insulin that was causing the problem, then the patient had to be restarted on regular insulin first. On the scale situation, you have a scale. The scale is set up to tell you how much insulin to give or how high the blood sugar is. And then you eventually have to reinstitute long-acting insulin, such as NPH, if the patient was on NPH before, to try to get a new dose set up for the patient, keeping in mind it is no longer the right thing to do to try to control a diabetic patient's blood sugar very tightly. It just doesn't make any sense. It's best to try to keep the fasting blood sugar somewhere around 130, in that range, because once the patient eats a meal, it's going to raise it to above 150, 160 after the patient eats a meal. So there's no benefit for the patient at all, zero benefit. This not used to be the case way back. Now it is the recommended thing, never necessary to tightly control the blood sugar. You're creating more problem for the patient. Because each time the sugar goes down, as I just mentioned, below the normal range, that patient is beginning to develop symptoms of hypoglycemia that's causing damage to the patient, in particular to the patient's brain. And if it happened, the patient has been diabetic for many years, it is inevitable that they're going to have hypoglycemia on and off. Each time the patient experiences a hypoglycemia, that each time the brain is getting damaged. And all that things adds up eventually, and you wind up with chronic brain damage of one type or another. It is absolutely necessary to teach the patient these things. The Diabetic Association have people out there, or different hospitals have people out there who are basically diabetic instructors who would really teach these people what to do. And you give them literature to read so that they know what to do They have to know what to do in an emergency situation to save themselves, or those who are taking care of these patients. If the patient is a child or the patient is very elderly, those who are in charge of the care of the patient must be taught what to do. And the event something quickly happen so that they can take action before help arrives. Nothing is wrong by giving the patient a glass of orange juice. Every diabetic patient of mine and other doctors have always walked around with some candy or other sugar-containing stuff in their pocket or somewhere in their bags or whatever, so that the minute they feel the symptom, they know something is wrong, they right away grab some candy or cookies or whatever they have, or some soda. They drink it quickly or chew it quickly, swallow it right away to help themselves until help arrives. It is a good thing to do. Almost always, you cannot be diabetic on medication, be it oral hypoglycemic medication or insulin, and walked around without having some sweet-containing material on your person, so that you're taught by your physicians what to do while you're still awake to save your life. Because if you don't do it and then things get worse, then you're not able to follow instructions that were given to you. So in an emergency situation, you must quickly grab some candies or some cookies and whatever and chew it. And if you happen to have some soda or orange juice in your pocketbook or in your person somewhere, you drink that. That will transiently help you until help arrives. Those are the things that you must tell all your in other words, the diabetics individual must be educated as to what diabetes mellitus really is and how to help himself or herself in an emergency situation until help arrives. Because if you don't do that and you fail to comprehend what is happening, then it's too late, because you become so confused, which is one of the common symptoms of severe hypoglycemia, is confusion, and followed by seizures, and followed almost always by coma. So how can somebody help himself or herself then coma? Especially if this individual is living alone. By the time they're found, they're already dead. Diabetes is a serious, serious medical problem. Of all the chronic problems that I have described to you the last 10 shows, all these things sometimes you can arrive on time sometime to help you. And hypoglycemia, there's no such thing. Because once you're confused, you're confused. Once you start having seizure, and all of the complications associated with seizures can develop, and then you go into coma. You cannot have a diabetic patient that you're providing care for without taking the time to educate them as to really what it's all about. It's better for the blood sugar in this setting to be higher than to be lower, okay? Because the state of high sugar that causes people to get into trouble is at a high 300, 400, 500, 600. Okay, so there's plenty of time for help to arrive to help in that setting. But when you're hypoglycemic, you may have a phone next to you, but you can't use it because you're confused and become so anxious. And sometimes these individuals develop acute cardiac problems, such as cardiac arrhythmias can develop. That's where the palpitation comes in. So this is a serious disease. Serious disease, diabetes mellitus is. And as I stated before I started talking about that, you proceed to take care of the patient in the emergency room, in the patient injury office. Nowadays, many of these big medical groups have facilities right there. They can do their lab tests right there. And they can quickly step in and help the patient. And many of these big practices have nurses with them as well. People like me who solo, I don't have those kind of facilities where the patient do the best I can quickly and get the patient to the ER. And then the ER work in conjunction with the ER doctors and nurses and try to save this patient's life. So hypoglycemia, the body cannot function, the brain cannot function if the sugar is too low, because then oxygen cannot be processed properly. This is the lack of oxygen that causes the confusion. It is the lack of oxygen that causes the seizure. It is the lack of oxygen that's going to put the patient into coma. So now that you understand that, your patient must be in close contact with the American Diabetic Association. They become a member of it. They receive literature weekly or monthly or bi-weekly. And some of these patients are so good at it, they can hold seminars themselves, literally, among themselves to teach each other as to what to do. Because, as I stated earlier, there are many, many other conditions that can cause somebody to become hypoglycemic than diabetes mellitus type 2 itself, who's on medication. Many, many other conditions. And next week I'm going to go into great detail to explain some of these things to you the best I can, so that you understand that if you have these problems. I'll give you a classic example. Let's say nowadays a lot of folks are having bypass surgery for obesity, etc. Well, when you do that, the surgeons are great surgeons, they do a fantastic job. But you must realize that there are complications. And those complications, 100% of the time, after the surgeon did a great job to do the bypass, are medical in nature. And one of these complications happened to be severe hypoglycemia, what's so-called reactive hypoglycemia. Significant percentage of individuals who have had gastric surgery wind up with chronic hypoglycemia. These surgeries are very important. That is the reason why sometimes people who are diabetic and obese, after the surgery, the blood sugar normalizes. Now you understand why, but sometimes it normalizes too much and the blood sugar becomes chronically, intermittently too low. That's a dangerous situation. Dangerous situation. Important though the surgical procedure is. Low B12 is a chronic problem associated with gastric bypass surgery. Low iron, ferroportin, which is the substance that you need that allows you to absorb iron, is located in the duodenum. So if that thing is bypassed, that organ is bypassed, you're going to spend the rest of your life with low iron, because you don't have ferroportin on board that's going to allow you to absorb iron. You could eat all the iron you want. The only way you're going to resolve that, you got to go and get Venofer intravenously every now and again. That's expensive. Insurance company don't want to pay for it. And yet, These surgeries are very important. They're crucial, but you must know about these things. It would be shocking to you to know that I have certain hospitals that I practice in. Not a single time have I ever been called in medical consultation, because there's a whole medical part of it that has to be discussed with the patient before surgery is done. Never been called once. And if I were to sit here and disclose to you, which I'm not about to do, who in this country, who was the physician that was given the honor of setting up the protocol for this entire procedure for the country, for that matter, for the world? You could figure that out for yourself. Because in this country, and I'm sure it happened to the rest of the world, the people who are in power in medicine in this country, the major organizations, they have certain doctors, physicians that they choose as a privilege. Would you please set this protocol for me? For no pay. But that's the way protocol are set up. And yours truly, for a reason you might figure out on your own, have done several such protocols. But it is secretive. You will never know who did this protocol. You're not supposed to. One of the most interesting things about my career, I have hundreds of stuff that I have done for the field of medicine across the world that will never be known to the rest of the world. I'm not unique. We sign a document, we see it as a privilege and an honor. We ask by these big, powerful people to do these things. We do them, we turn it over to them. You will never know for the rest of life, as long as life exists, you will never know who did these things. You're not supposed to. Okay? And I'll leave it at that. So hypoglycemia then is a very dangerous situation. It's a very dangerous part of the disease of diabetes mellitus. It happens intermittently all the time, and people who are very intelligent, very brilliant, but unfortunately this is the way the disease is, up and down. It happened once, they fix it, it happened again. Each time it happens, it's problematic. Serious problem. So that's one of the reasons why it is such a chronic disease and such a dangerous disease. Listen, I'm going to stop here. Next week, I'll wrap up the series again by talking of non-diabetic associated hypoglycemia. So long and bye-bye.